they're always going to ask you, what questions do you have for me?
Oh, yeah.
And that's like the worst question to get.
That one can trip you up.
The podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derek Davis, a physician specializing in pain management. In this episode, we speak with Dr. Kevin Vu about pain fellowship applications. Dr. Vu is from Austin, Texas. He attended UT Dallas for undergraduate, where he was a part of the accelerated program and he studied biology. He subsequently went to medical school at UT Southwestern, and then he moved up to Boston, Massachusetts to do his residency in physical medicine and rehabilitation at Spaulding, and he is now in fellowship subspecializing in pain medicine. Full disclosure here, Dr. Vu is my co-fellow. We're both in the same fellowship program at Brigham Women's Hospital. I'm a little bit biased here because I love this program so much, and Dr. Vu is an amazing, incredible person, so thank you so much for your time, Kevin. But speaking of programs, pain medicine is an ever-evolving field. Getting into pain fellowship can seem a little bit daunting to some of us in residency or in medical school if you're thinking ahead. Because despite having interest in the field, it may prove difficult to get significant hands-on experience while in residency or in medical school. So if you're a medical student or resident, hopefully this episode sheds some light on the various aspects of the application process for fellowship. As always, thank you so much for watching or listening. I hope you learned something from this episode and enjoy it.
Let's go ahead and get started here, Kevin.
Great.
For those at home that don't know, Kevin is 7 foot tall, and I just need you all to know that. We're not going to stand up during this podcast, so you can't see it.
I think that is the first thing that most of the fellows say to me when they met me, like, oh God, you're tall.
Because we only see each other, like, virtually for a while, like when you were, like, I think away in California?
Yeah, that's right. Yeah. I was in California for a little bit.
You got here in the clinic, I was like, wait a second. So tall.
I had that remarked to me the other day, actually. I was on Zoom, and I met someone that I'd only met on Zoom. They're like, whoa, you're much taller than your Zoom picture.
Yeah. Your Zoom picture. Oh my gosh. That's I don't know if you know him, but Dayton was a co-resident of mine at Emory, and from his interview picture, he looked so much shorter. But then you see him, he's like 6'5" or something like that.
God.
Anyways, okay, getting down to brass tacks, this is kind of a unique episode because it is more about the field of pain and pain applications for fellowship than like individual diagnoses of pain. And so thank you for being here, Kevin. And I just wanted to ask initially, so why did you choose pain, or more importantly, why did the pain life choose you?
I can give a little bit of background at least. I'm originally from Austin, Texas. I came here to Boston, Massachusetts now to do the rest of my training. I was at Spaulding for PM&R, and such as that, we are like brothers, I guess, doing the same background. But in that sense, I'm doing a pain fellowship at Brigham. And I think the reason why I chose to do pain over doing something like general PM&R or other subspecialties, I think it really encompasses the whole MSK, musculoskeletal aspect of PM&R. I think that our training in PM&R is pretty robust for the most part in terms of dealing with all the extremities. But when it came to the spine, or when it came to something central, I found that we were turning a lot of patients away and saying, go see the spine doctor, go see the pain doctor. That's not what I do. And so I felt like, because the majority of the complaints that I saw in a general practice was spine or pain, I felt like having that training was going to be very useful for just treating the whole range of musculoskeletal issues primarily. It is still both kind of an art. I think that's the second reason. I think a lot of medicine is very much a science still, as it should be, but pain is so subjective and nebulous. It requires a fine touch. That's not just an algorithm. And I think in our field, we see so many things that are not on an algorithm, and there's so many approaches and how you kind of talk to patients. I think that's brings a lot of nuance, brings a lot of challenge, particularly, but is very exciting at the end of the day.
Definitely. So you decided pain during residency then?
Yeah.
Okay.
Yeah. I think when I was an intern going into PM&R during my intern year, I had a general knowledge of pain, but I think having had a little bit more experience during my intern year, during my PM&R sort of training, I was like, this is awesome. It's technically difficult, it's procedural, but it's also very much of a soft science still. So yeah, all those things during residency.
Awesome. Yeah, I'd agree with that. Did you have any exposure when you were in medical school?
Not really.
Mm-hmm.
I think it's such a challenge to even get exposure to PM&R.
Yeah, that's a very fair point.
I think a lot of our applicants are like, oh yeah, I've never heard of PM&R, or like, oh, this is the first time I'm hearing about it. But no, for the most part, it was just my PM&R sort of exposure that I focused on in med school, and then pain came later.
Interesting. So looking back, is there anything you think, because I think, for instance, myself, I actually got interested in pain in medical school.
Mm-hmm.
Looking back, would there be anything you think you could have done to get some of that exposure in medical school, or I guess, sort of prepare for trying to pursue pain?
Yeah. It's tough because I think medical schools have a robust pain department, and certainly not all medical schools have their own standalone pain department. Sometimes pain providers are like in neurosurgery or orthopedics or under anesthesia, and those are all places a PM&R person or interested person may not venture to. But I think if it would be nice to talk to the department and be like, what are all these subspecialties of PM&R? Because I had no idea as a medical student, like TBI, spinal cord, neuromuscular, even, like those are not words I was familiar with.
Right.
And so I think I would have asked more about the subspecialties that you can do after a general PM&R training.
Mm-hmm. Yeah, absolutely. During residency, did you think there was anything you did throughout residency that helped you, and you don't need to name specifics, but in generalities, was there anything specific that you did that helped you stand out, you felt like, during interviews for pain?
I think there were a couple things. I think the foundation is like, I always say this, like the 3 A's, right? You're able, you're available, you're affable. Like, I think if you're those 3 things in residency, that gets you 80% of the way. I think you make a good impression on people, you work hard, and whoever your pain person is, hopefully you have one, they're impressed by your demeanor, by your sort of attitude. I think that gets you so far. So being a good resident, one, right? I think that to highlight some of the more specific things, I did show an interest in research. Not everybody needs to show an interest in research. I usually tell most people, like, as long as you have a passion that is somewhat pain related, that works. I had someone I knew who was a lot more volunteering heavy and a lot more participation in sort of the societies that kind of are the national societies for pain. And that brought them very far. So I think really what interviewers, I think, look for is passion for the field, whether that's academics, if you want to publish, or if you want to volunteer, or you just want to like have some sort of experience in that field, like taking away rotations or electives. Those things, I think, get you pretty far. Yeah.
I completely agree with that. That's something that I have tried to voice as well to anyone that, has expressed interest to me about pursuing pain, is not necessarily the research that you've done within pain, or if you've done any research at all, but maybe if you've gone to conferences and you show a big interest in the field of pain. That seems to be, at least for me during interviews, one of the things that helped me stand out during, in residency, the things that I did that kind of showed interest in the field at all.
Yeah.
Were there any electives you felt like you took? Not necessarily within pain, but maybe, I did an elective in IR in intern year, which was a huge waste of my time. But, so I don't know if there's anything in particular that you felt like.
I will say this. I think, so during my intern year, I was very, very, very lucky. The community hospital at which I practiced with actually had an affiliation with a neighboring pain practice. So that was an elective we could actually do as an intern. And then, similar to you, I had a radiology rotation that I felt was completely useless. And I convinced my chief at the time to just be like, hey, no one's at the pain practice right now. Just let me leave radiology and go to the pain practice. And that sparked a little bit of something in me. I know some of my co-residents during their elective time actually reached out to neighboring private practices, and they were willing to bring them on board and let them at the very least shadow. But having that experience is really helpful. And I think the other thing that I'll highlight is if you are in sort of a rotating sort of place, potentially asking to drive the C-arm. I know not a lot of people do that, but like that's been a really, really important skill, even in like a clinical setting, is knowing how to drive the C-arm, like prepares you for what you want as an attending when someone else drives the C-arm. You can be like, hey, like, I want this angle based on someone else, you know, but the attendings that before I've seen ask of me. So I think that's really important. Even optimizing an image is also a super valuable skill to have.
That's so true. I think because pain is relatively small and some of the procedures we do or interventions we do aren't well known, especially even in the radiologist like technician world, it's kind of hard to voice what we're looking for. And so being on the other side of things can help you voice to someone that's actually operating the C-arm. So getting that elective time, and that's a really good point too, is that it may not be within the institution, but if you have affiliations with you know, like even private practices and can talk to your program director about, hey, like I want to do this. Like, can you just let me? So I think that's a really good idea because I didn't think about like, what do you do when you don't even have a pain program?
People cold called.
Yeah.
I remember talking to people who just cold called private practices and they're like, hey, can I come? And they're like, yeah, why not?
Yeah.
So they did that and they actually even got hands-on time. Like it's a very different environment out there.
Yeah.
And I think the private practices I've been with who have let me do that, as long as you show again those 3 A's, they're willing and ready to have you.
Dang, the 3 A's. I learned about that in residency. That brings me back. There's one attending in particular that actually said that exact thing.
Yeah.
Yeah, I wonder if you guys are related or something like that.
Probably. It's the age-old adage, you know?
No, that's adage. Yeah, that's good. So in terms of letters of recommendation, how did you approach your writers for that?
I think I set a foundation pretty early. I think in the pain fellowship world, letters of rec are really, really important. Exactly like you said, it's a super small world still. And I remember even during an interview, one of the interviewers was like, I know this guy directly. I'm going to text him right now. Like during your interview, I'm shooting him a text. He's like, they were like, oh, like I'm shooting him a text right now to see how he feels about you.
Yeah.
And so like when I heard that, I was like, oh my God, I'm glad I chose that guy. Yeah, I'm pretty sure he likes me, I think. I set a foundation pretty early. So like people who I thought maybe were going to be nice letter writers or important maybe, I just volunteered and I was like, hey, I want to do a project with you. I want to get to know you. Or if I was rotating at an outside institution, I was like, hey, I want to work with that guy or girl, you know? All those things kind of lay the groundwork for building a relationship. I think if any resident or someone was like, hey, like, how can I help you? Like, I'll write some research for you. I don't think anybody would turn them down for the most part. Yeah. And that's a great way to kind of get your foot in the door.
Yeah.
And of course, like, if you are, and hopefully you are maybe doing an away rotation with some letters or even at your own institution, again, just being the best resident you can around them and taking initiative and reading about the patients, reading about the things that you might encounter for the day ahead of you. Like all those things, I think they don't always pay off, but for the most part, when the opportunity comes, at least you'll be ready for it. At least when the opportunity to impress comes.
Absolutely. Do you think that you need letters from a pain doctor specifically?
I've heard both. I personally think it's probably in your best interest to have a pain doctor write at least one of your letters. All the letters I actually included in my application were all from Payne, barring like the program director, the required one. They were all Payne. There were some that had like a PM&R background maybe, or had anesthesia background. I've heard of people including particularly like, good letters that were not Payne, and they also did really well. So I think the underlying message is choose someone who can write very well about your strengths and who knows you really well.
Okay, so it's not necessary, you would say. You've heard people having it.
It's a bonus, but I don't think you necessarily need to have I would have probably advised against all your letters being non-Payne.
Yeah.
Like have one Payne doctor maybe, but when push comes to shove, I think if you have a really great letter from someone who's not Payne, but can maybe talk about how you treat patients or how you clinically are, that I think still gets you pretty far.
That was kind of the advice I was given and kind of what I did as well. I think 3 of my letters were from, spine/pain people.
Yeah.
Because in the PM&R world, I guess depending on where you practice, even if you've come from pain fellowship, you still might kind of be in just a spine niche because that's the majority of the patients you'll see.
Yeah.
So that's kind of what they were at my facility, but nonetheless, they were still, pain trained, pain fellowship, ACGME trained. Did you attend any conferences or workshops in residency you found particularly helpful?
I am slightly biased because now I'm in like these sort of conferences as a little bit more of a higher level now, but I found that IPSIS was particularly helpful. I think it's a lot more approachable from a PM&R standpoint. They kind of were originally sort of PM&R, and so like that builds a very open sort of conference vibe. You can meet a lot of cool people there and a lot of great people who are really, really approachable. I went to the ASRA. I know ASRA has their big PD sort of program director meet and greet. I did go to that. I don't particularly know how useful that was, but it was really nice getting FaceTime with these program directors. I met some, and I knew I liked some, and I knew I didn't like some, right? Or I maybe liked them a little less.
Which is just as important,
Exactly. And I think like when it comes to choosing a program, like they do set a precedent, like culture comes kind of from the top. And so if you do mesh well with the program director, odds are you're probably going to mesh well with the rest of the culture there. So I think it's nice going to that meet and greet because you get a pretty good idea and you get to talk to people, and I think they rotate people around and you meet everybody. It's not a bad idea to go. Is it completely necessary? My argument would be no. But again, it's like if you want to highlight, a passion, right, for pain, that's one way you can do so. Yeah.
I attended APM, American Pain Medicine, an IPSIS conference. Did you attend? I think Aspen as well when I was in medical school. Residency, and I really enjoyed them insofar as it gave me an insight into what the field's all about. And I felt like that was helpful because just like PM&R, it's very small and you're like, what do you guys actually do? And so for me, I felt like it was helpful in that regard. It's like, if you don't like it there, then you'll be like, well, I may not just like this field at all. Whereas like, that's when I found out that I really liked the field, is that everything everyone was talking about for me was like really engaging and fun and cool and stuff that I want to be a part of. And I felt like very interesting. So for me, like it was not as much about networking as it was about just kind of feeling out the field. So.
Yeah. And I completely agree. I think if anybody who's met me in real life knows, like conferences, like I'm not amazing at networking, nor do I seek out to be amazing at networking, to be honest with you. It's great going with people I think if you're a resident who's like a little apprehensive, like one, get used to introducing yourself and cold calling people. Like that is something you unfortunately have to do sometimes. But the better idea, I think, is to talk to fellows or talk to attendings and be like, hey, like, what conference do you like to go to? And can you take me with you? Help me shake some hands or help me get to know people there. That's probably like the most useful thing to do.
Do you have any recommendations on how to write or nail a personal statement? I'm terrible at it. Outside of using ChatGPT.
I mean, we're so close to it. I'm pretty sure I used ChatGPT to draft.
Really? Did you? Yeah. I mean, like
my personal statement.
we're like 4 pipettes away from using our DNA for it to just write everything for us from now on. But
I think I tend to kind of base my personal sort of statements around like a poignant sort of encounter. And I feel like that's always worked. Like, as long as you can demonstrate, hey, like, this was like meaningful to me, and here's why I think I'll be a great fit. I think that's mostly it. I feel like, to be honest with you, I feel like playing it safe on a personal statement is totally okay for the most part. I think the only thing you can do is you write a really out there personal statement and you might shoot yourself in the foot.
Yeah.
It's totally okay to have a bland personal statement as long as you display passion maybe somewhere else or in your statement or when you meet someone. But for the most part, I feel like you shouldn't stress too much about your personal statement, and we're stressed more about like, oh, like, how can I demonstrate like my commitment to the field? You know?
Yeah, those are good points. For me, what was particular and interesting about writing my personal statement for pain is that it actually made me realize I do like the field, because it was like, what are the things that I like about pain? And, I picked 3 things that I liked about pain, and I wrote about how my past helped encourage me to understand why those 3 things are things that I enjoy, and how the future is very exciting about how those 3 things will be, present in the future for the field and for me to enjoy it. So
did you get mentions about your personal statement during the interview trail?
I think 1 or 2.
I think I got like 1 or 2 too.
Yeah.
Like, I think that's how I'm trying to like kind of piece it together for someone who's listening. It's like, I don't think I got asked that much about my personal statement.
Right. Yeah. I mean,
I don't remember, but I don't think I remember getting grilled on it.
Yes. Yeah. I think that it's funny because, the personal statement sort of situation is that you can put so much effort into it and put so little effort into it, and you'll still get 1 or 2 mentions.
The payoffs are probably pretty minimal.
That's probably why it's so hard to encourage yourself. It's like, oh man, I got to write this personal statement, but does anyone care? Is anyone going to read it? Do you think that having significant experience with procedures prior to fellowship is necessary, is helpful? Just what are your thoughts on that?
I don't think it's necessary, and I think it's nice. It's a bonus, right? It's like if you walk into the pain fellowship day 1 and you've got a pretty good familiarity with maybe not so much the hands-on, but even the technical, like how to do the steps in your head sort of approach, that's still really helpful. I mean, the more you see, the more you experience, the better it is kind of walking in. Do you absolutely need it? I would say no. I think a lot of pain fellowships, or hopefully the majority of pain fellowships, have a pretty good base of procedures to work off of. And as long as you engage and want to do those procedures and seek out those procedures, you'll walk away fine. Like, a pain fellowship's 1 year, so like in all terms, like you're probably going to be learning after fellowship too.
Yes.
But I think whatever you can do to accelerate that, I think is nice. I think I've talked to people who have gone into pain fellowships with a lot less. I think I spent a lot of my residency like trying to seek out time to practice and see these procedures. Right. I think people who maybe didn't do as much are totally fine. It's just a steeper learning curve.
Yeah.
Yeah,
and it's almost not about the procedures as it is about the imaging. Like you had mentioned, we'll still be trying to learn these things after a year, because a year is a very short period of time. And it's not even really a year, it's not 52 weeks. It's even less than that. They're actually getting the fellowship with, if you kind of take out the vacations and the conference time and all that sort of stuff.
Exactly.
So if you get I got a little prompt back there. If you
wow, I'm glad you had that back.
Atlas of Image-Guided Spinal Procedures by Dr. Michael Furman, which is an awesome book.
If you want to read anything before fellowship, that's probably the book to read.
Kind of, reviewing.
Or skim.
Yeah, right. Exactly. Just reviewing fluoroscopic anatomy if you can. What aspects about the whole application process did you find to be the most daunting?
I think it's back in our day, which is a year ago, they didn't have limits on like what you can submit. Now they have like a 10-item limit, right? Like you can only put like the top 10 most significant things or something like that.
Oh, really?
There's a limit now to how much you can put on your resume. Correct? I may be misspeaking. This is at least how it is for residency, and I think this is how it is for fellowship now. So like, I felt like the most challenging thing was just I think you can put as much as you want on a resume, but the challenging part is highlighting the things that are most important to you, right? And I felt like when I was looking at maybe not my CV, but my overall resume, I wanted to trim a lot of the fat to really make sure that my interviewers were like going to ask me things I was really passionate about. So, I mean, like, there are a couple projects that I was like, I'm going to like leave this off maybe, or like cut it out, because I felt like having more quality and like projects that really, really were meaningful or demonstrated like a pretty good commitment. Those things were going to stand out more than quantity. You know, I could probably put as many posters as I want on that thing, but odds are they're going to ask me about something that I'm not so enthusiastic about if I put a ton of work out there.
Right.
So I felt like that was really hard, narrowing down that scope. And then like just displaying well-roundedness is hard. Like, I don't think anybody can do it all at once, right? Like, you can't be a great volunteer and throw 20 hours a week and you're volunteering, and then also be a great academic.
Yeah.
You know? So like, it's such a hard balance to build potentially a resume that's like demonstrates well-roundedness. It's okay if you're not well-rounded. It's okay if you have a specific focus. I don't think people should take that message the wrong way. But you also shouldn't stress yourself and be like, oh, I need to do this volunteering thing or else I'm going to look terrible on paper. Just doing the things that you like and that you have passion for, I think, is what you should focus on.
Do you have any advice for people that may find it hard to fill all the gaps? That is to say, maybe they don't have as much research or as much volunteer time, but yet still have quite the passion for pursuing the specialty?
I think that if you do have that passion, just there are lots of ways to try to pursue it, right? And so put that energy toward, if you feel like academics is something you lack and you really want to try your hand there, there are within the like societies, there are people who do research and like who kind of like mentor people doing research. I think asking like fellows or even asking attendings, be like, hey, have you seen an interesting case? Like those baby steps, I think people appreciate seeing on a CV or a resume, right? It's like, oh, they took the time to like write up a case. Right. They took the time to do something like that. That shows some initiative. As long as you're showing an initiative, I think that's important.
Yeah, I mean, it's so hard to get really big projects done within residency and everything. So, you know, even doing things like posters and cases.
Yeah, like even the small stuff, like I think it shows some commitment of your time.
Absolutely. What are some questions that if you can remember any, because I mean, even though it was like a short period of time ago, it still feels like forever ago. Are there any questions that you can remember that you encountered during interviews?
I did get pimped once or twice.
Yeah? Oh.
Yes, I remember. And that's why maybe you should, you should at least be looking, if you're interested in pain, you should be seeing these procedures at the very least.
Right.
Or having maybe read a few of the procedures.
Yeah.
I'm like personally, I hate shadowing. I get it. It's not fun.
Yeah.
But I do think if you're going to shadow, you should try to make the best of it. Like, practice running the procedure in your head. Like, I always ask myself, even during inpatient, when I'm like working with a fellow, I'm like, what would happen if my attending just keeled over right now and the patient's open and I had to take over? Right? Like, so like you should know hopefully some of the steps in your head about like, okay, here's what I would do in case things go awry or if I had to take over.
Right.
Because I definitely got asked that.
I definitely got asked
interesting.
That
during the interview process. Wow. Have a good, everybody's going to ask you, so tell me about yourself. Have a good answer for that. Like the worst thing you want to do is open up an interview.
Really good advice, honestly. Because like you don't think about it. I mean, we think about ourselves 24/7, but like never how to, I guess, give a narrative about ourselves in like a succinct way, like an elevator pitch.
Yeah. Always have I wouldn't say always, but like they're always going to ask you, what questions do you have for me?
Oh yeah,
and that's like the worst question to get.
That one can trip you up.
But like have something.
Yeah.
I think my default was like, oh, how do you build a culture here? Like, how do you approach like fellows, or if there are conflicts with fellows, how do you approach that?
That's also like
have a good, hopefully introspective question up to that question. Fortunately, those are aside from that, I felt like maybe not everybody's experience was like that. I felt like most of my interviews were just like shooting the wind about like my hobbies, or they would usually cherry pick something from my resume. So they'd be like, hey, well, you worked on this project. Sounds super interesting. Tell me about it. So if you're going to put something on your resume, know what it is.
Yeah, that's true. Yep.
You put a college project on there, like personal experience, you put a college project on there, you don't quite remember. They're going to ask you.
Yeah, it always comes up. Yeah, it comes up.
It's going to come up.
Yeah. So I had done stuff on methamphetamine abuse in undergraduate. And they're like, so you're looking for addiction sort of related things in medicine or in pain medicine? I was like, no. Yeah, but you're right on the procedural aspect. There were questions about, have you done, X, Y, or Z? And fortunately I had come, at Emory, we actually do quite a bit of those procedures in residency, which was nice. But I was thinking like, I haven't done all of them. And it made me feel like, are they thinking that I need to have done these in order to like get into the program? And that kind of worried me. Turns out that it wasn't that important. And I still don't think it is, but knowing what the procedure is, I think is, because that way you'll know what like the quote unquote bread and butter of at least the procedural aspects of the field are. Yeah. I think that's important for you to show that you know that, just kind of like you would know what CHF is applying for, internal medicine residency.
You have the same lexicon.
Yeah, exactly.
Like it's like you can communicate with the person interviewing with you.
Yeah. How would you give any advice on how to arrange your rank list?
That is so hard. I think my filters were primarily geographical location. You're always going to have somewhere you probably don't want to go. I didn't really want to go to the Midwest. I didn't really want to go to the South that much. So those were already kind of filtered from my rank list and from my application list, to be honest with you. I think my number one priority is usually how I feel the program's culture is. That's why I asked about it. Like, I feel like if the fellows that I interviewed with or spoke to, if I clicked really well with them, then that was like great. That's like my number one compass, because I feel like I could do anything for a year. I mean, you could put me in the worst place ever, and as long as I had great fellows and good support, we'll get through it. No problem. You could put me in the best program on this earth with the worst people on this earth, and I would not be okay. Right? So that was a really big filter for me. I do this for every rank list I do, and not everybody does it. There are like rank list like ELO programs out there. Like you can put all the programs into like, you can just Google like ELO. It's like a ranking system for lists.
Does that mean Electric Light Orchestra?
No, I can't remember what it stands for, but it's like if you're ever playing video games online, it's like a ranking system.
Interesting.
That you can just I threw in all the programs that I was interested in putting on my rank list, and it literally just pulls up all the programs head to head, and it asks you which one you like more, and then spits out a list at the end.
What?
Yeah. I did that for residency too. I think if people want to play any video games who are ranked online, they understand what I'm talking about. Okay. But basically, it's a head-to-head.
Okay.
They do multiple head-to-head matches of all the programs, and I would just look at the program name. It'd be a gut check, and I'd be like, I like that one, I like that one, I like that one, and it spits out a list for you.
Dang. That's cool. You have to show me that, but that's you can just Google it, I guess. For people.
ELO ranking list, and there's probably someone who has like a little free little thing. You just put your list in and you throw it in and get to your list. That's like kind of the weird way to do it. I'm certain, like, again, geographical. I think if you have a specific bias toward procedures, or if you're more holistic, which is totally fine, there are programs that are more procedural. Brigham is very procedural.
Yes.
And there are programs that are less procedural, but just as effective in terms of teaching you like holistically how to work through pain.
Yeah.
That was also a big filter.
Yeah.
I knew it wanted to be procedural.
Yeah.
Not everybody does.
Yeah, absolutely. Okay. Speaking of procedures, regarding PM&R, coming from a background, do you think what disadvantages and advantages has having a PM&R background given you now in fellowship and in pain?
I think we are so well poised as PM&R from an anatomical aspect. I think, when we're talking about spine anatomy, we're talking about extremities, we have such a power to generate a broad differential. Someone who walks into the clinic maybe doesn't have as much of an MSK background. They're probably just like, hey, nail, hammer, that's spine pain, right? Whereas PM&R, you come from a field where it's like, okay, is it like something else? Is it like a soft tissue disease? Is it a neurological disease? Is it, psychogenic? Like, I think we're really, really good at that.
Yeah.
And I think procedurally, like, we do pretty well too. Ultrasound is challenging.
Yeah. It is.
I would even almost say sometimes ultrasound is more challenging than fluoro.
I would agree with that.
Most of the time, actually.
Like holding your hand. Yeah, I mean,
Really
there's just so many aspects of it.
You can get a really great technical background from PM&R because you're a combination of anatomy and prowess, kind of with different sort of modalities.
Yeah. Puts
you in a great position for a pain sort of thing. I would say the disadvantage is PM&R is not the predominant specialty in pain. So you do have to be cognizant of that. You are a newcomer in some ways to this field. I think it's more and more PM&R now, but you still have to break that ice sometimes where it's like, oh, we used to only take anesthesia, but now we're looking at PM&R, and you have to convince them that you have the background, you have the skills, you have the resume to be just as successful. And that's hard sometimes.
Yeah. I often wonder, at what point do we come to the same outcome? Does doing a physical exam help in expedite our diagnosis and then subsequently dictate what we do in terms of our treatment? Or is it like, so what does this physical exam component add to the patient encounter? I would argue quite a bit. And in addition to the physical exam component, it's just, I think, part of medicine that doing a physical exam has just been in like the lifeblood of what medicine is. And patients really like that. And it gives you a time to kind of bond with your patient as well. And I really have found that to be a particularly advantageous part of having a PM&R background. Disadvantages, I've felt, kind of how the field of pain is moving with these more, quote unquote, advanced procedures.
Yeah.
How the anesthesia based specialty and even EM have had a lot of time with kind of very, how would you say it? Like, in the OR, very intense scenarios, basically. Yeah. And, they can watch vitals very closely while, the patient's under anesthesia for whatever sort of intervention you're doing. And that's been great, being surrounded primarily by our co-fellows who are anesthesia background primarily.
Yeah.
Kind of learning from them in that regard. And so those things, I think, are kind of, in a way, a disadvantage. Like you had said, we're kind of the newcomers in this field, even though that's changed significantly over the past 5 years with anesthesia having dropped off quite a bit in their applications to the specialty of pain.
Yeah.
So speaking of fellowship, sort of things we do in fellowship, how would you say the fellowship, we're both in the same fellowship, so that's
you tell me.
It's like you can turn this Uno card me on this one, but how is fellowship structured?
I think it varies. So, like, of course, I'm one perspective, but our fellowship is kind of structured based on monthly rotations. We do have this sort of home base, as most fellowships do, where you do a lot of your clinical work, your procedural work. And similar to other programs, we have satellite locations. So we're going to like the VA, or we're going to a different hospital with a kind of different flavor of pain and how they do things. Or some programs have like a private practice attached to them, and they're going to the private practice to see how things are run on that side. So for the most part, I think fellowships are usually structured around this monthly sort of rotation, with whatever flavor of sub-niche or subspecialty or even subspecialty way of doing things, right? I think we're lucky that we have, and not everybody agrees with this, but I think we're lucky we have inpatient OR time, right? Not every program has OR time built in such a volume, and not everybody wants that. But I think that's also like great. Personally speaking, I love Brigham, but we're very biased.
I mean, I think this program is the best in the world, but I'm pretty biased in that regard, and I can't have been to every program, so I can't, speak to those. But yeah, you're exactly right. These monthly based rotations, and whether it is you get some sort of additional supplemental insight into the PM&R background for those that were anesthesia based, or some psychiatry background. Working.
I think that is mandatory across fellowships.
I think you're right.
You get like at least a couple of weeks exposure in PM&R or some other sort of subspecialty adjacent to pain. You get some. You're supposed to get some exposure there. Yeah.
Do you think you're getting enough hands-on experience? I know that's not really. I mean, just for everyone that I suppose it's not at our fellowship or fellowships that are more procedural based. Do you think that you're getting enough, and how important is it that you think you are? I mean, that you are.
Yeah. I mean, I think the obvious answer is yes. Overwhelmingly yes to the first question. We get a lot of volume.
Right.
Volume that I can't even really imagine. And again, I think our attendings are great. They're hands off, right? At this point in time, for sure. Even past the first month, they're already hands off. So I think it's incredibly important, dependent on if you want that. Not everybody needs to or wants to practice pain in such a technical way. And certainly pain is not just, again, I think everybody refers to it as being like a needle jockey.
Yeah.
You don't have to be a needle jockey either. Yeah. I do think it's still incredibly important. Even if you were to swear off doing injections for the rest of your life, you still need to know what exactly it entails.
Right.
Odds are, if you're not doing injections, you probably have someone else doing injections that you need to talk to, maybe refer patients to. So that's still really important. And if you're going to offer injections, you should have, this is the opportunity, I've been told this is the opportunity to mess up.
Yeah.
And
you have support around you.
And have someone watching you, because in a year's time, less than a year's time, now almost 6 months, 7 months time, you're not going to have anybody.
That's not terrifying.
No one's going to be watching you. And the only person who's been watching you is your rad tech, and they may raise some eyebrows too, you know? So that's still really having as much hands-on time within, reason, hopefully, is vastly important, I think.
Yeah, I was thinking about this question a lot because, as you had mentioned, and as we're mentioning now, not all programs are built like that. And what do we stand for as pain specialists, pain providers? And I suppose that when you and I graduate, maybe what will be quote unquote called interventional physiatrists, what do we stand for in this field? And my hope would be that we stand for a holistic, comprehensive sort of specialist in treating pain. And so that's why I don't think it is 100% important, like you said, that you get a lot of hands-on experience with it. But I still think that, as you had said, if you are doing injections, you want to have had a lot of volume in it, because just like anything that's invasive, you want to be good at it. And, you thread the needle in
pun
trying
intended.
to be, sorry?
I said pun intended.
Yeah. Hey, dang. Yep. You try to thread this needle by not being a technician and being a doctor, not being a needle jockey. And now the concern is that, the field has moved away from a comprehensive pain perspective to a pain surgeon. Yeah. And, anyone who's a general surgeon or neurosurgeon or orthopedic surgeon knows that, we're not surgeons, and I don't think we would call ourselves surgeons. I don't know what your thoughts are on that term, but
we certainly are towing the line, I think.
Yeah, I mean, sometimes these, minimally invasive procedures are basically mini surgeries. And so I think it needs to be a conversation that I'm sure a lot of program directors are having now, but I think that also that people that are considering the field of pain should kind of look into as well.
Yeah.
How have you found balancing work life in fellowship?
I think that coming from a PM&R background, lifestyle is very important.
Yeah.
That's one of the reasons why I chose PM&R. It's also kind of one of the reasons why I chose pain as well. I personally, my pain fellowship, I'm not taking as much vacation, and that's primarily because it's 1 year. And I feel like I want to squeeze as much out of that year as possible. So if someone says, hey, we're doing 5 cases in the OR today.
Yeah.
I'm like,
Come in.
thumbs up. Like, I'm crying, but I'm like, like, let's do it.
Yeah.
Some people may see otherwise. I try to make sure, like, I used to really, really prep patients and like write the notes and I don't do that anymore for my own sanity and to protect that time that I have at home.
Yeah.
Sometimes programs might be a lot more heavy on the work out of hours, like educational opportunities or dinners. And while it was nice and fun for the first 2 months, I feel like many fellows now are kind of cutting back a little bit and saying, okay, well, I've had as much steak as I can handle, as much PowerPoints as I can handle.
Yeah.
I'm just going to take it easy after work today to go home and actually chill out a little bit. So I don't know how I wouldn't say that my life balance, I would say it's a little bit worse during fellowship, but that's because I choose it to be that way. And I want it to be that way because I only have a year. So I want to get as much experience as I can. Otherwise, I meet plenty of people who are the complete opposite. Even within our own fellowship program, people have very differing styles. And so as long as you're cognizant of the decisions you're making and, either making decisions for your lifestyle or for your education, then whatever works. And I think a lot of pain programs are pretty flexible.
They are. Yeah. I mean, I had one of my good friends, so I would call him one of my good friends. It's like, I'm looking for a program that doesn't have call.
Yeah.
Like, all right.
Which is excellent, obviously.
Nice. How was it? Were there any challenges transitioning from residency to fellowship?
There's growing pains.
Yeah.
The same growing pains. When you're doing a fellowship, you've probably run into the same growing pains starting residency. Very much the same. Yeah. Sometimes you're in a new system even, and you're in a new EMR, and you've got brand new administrators and people you don't know, and you have to email everybody. Those things are the same between, I think, universally, between programs and the transition between different stages in medicine. It's going to be the same way as an attending. It's going to be the same way as you progress or go to a new job. So at this point, I wouldn't say I'm used to it, but I know what to expect. And they largely fulfilled my expectations. I don't think you need to read before fellowship. I didn't have my nose in the book before trying to get ready for fellowship and impress on the first day. Most fellowships understand that whatever residency or background you have, probably don't have as much experience in pain. Yeah. And the argument is always pain could probably be its own residency, or extended training, just because of all the differences and scenarios that you've probably never seen in your life, which is, I guess, expected now in pain, but something I anticipated as well.
Would you give any advice to individuals with a PM&R background transitioning to fellowship? And I know it kind of depends on what fellowship you're going to, but even still, is there anything in particular you would try to share?
I would hold on to that PM&R knowledge. It's really easy to get swept up in how your program does pain, right? If we offer a certain injection or we offer a certain procedure, it's very easy to be like, close my eyes, like, you have back pain, let's try this procedure. I joke a lot with our attendings. It's like, yeah, I'm ordering PT. I think that's a valid conservative care option. Yeah. Not everybody's like that. Yeah. It's an ongoing joke. I'm like, oh, let's order PT. It's like, so you order injections too? I'm like, no, PT is great.
That's what I'm talking about.
Hold on to that. Like, you have a certain background, be proud of that background. It's very valuable.
Absolutely.
And that would be my large word of advice is, like, don't forget all the things you've learned in your rehab residency. Yeah. Because they'll come up.
I mean, I even, we're talking about pain now, but just PM&R, I still feel like that's a changing, evolving small field too. So, but that's a whole different podcast coming next month. PM&R. What to expect.
That is another topic.
Yeah, right. So what job opportunities have you seen so far?
There's I feel like I'm biased. I'm staying in Massachusetts. I'm coming from, I would say, a fairly recognizable program. Largely, I feel like the opportunities are, I wouldn't say endless, but bountiful. I think there are a lot of job opportunities out there. Certainly, some are better than others. It's easier to find a job in a place that no one wants to go to, or, has a population less than 100,000.
Why would you say those things about Missouri?
I'm not mentioning Missouri specifically, but
show me say shout out.
There are, I think, a lot of opportunities out there, and it's odd. It's like there are still a lot of private practices. More of them are being bought out by private equity or being absorbed.
Yeah.
But pain is still one of those fields where I feel like the more people I meet and talk to the field, there are so many people who are just striking it out on their own, which I don't think I feel like isn't typical of many fields. Pain tends to select for, I think, a very entrepreneurial spirit.
This is true. Something kind of almost marketing yourself in a way.
I don't know. I don't know why.
Yeah.
I think it's just the archetype that we have.
I suppose.
Maybe.
Yeah. Because it's elective, in some ways. It's like pain won't necessarily kill you.
And
perhaps that's why.
I don't know.
Just like dermatology, it seems that social media is filled with, skincare, as it is with pain podcasts.
I'll have to say, I'm not trying to market anything.
Yeah,
here,
right. Yeah.
Certainly, it tends to attract a certain type of individual who maybe be more business focused. And the way our field is you do have to be, whether you like it or not, you have to have an awareness of the numbers that you're doing and that you're approaching. And maybe that just breeds people who are like more cognizant of that.
Interesting.
Which is totally fine.
Yeah.
I mean, from an offer standpoint, I feel very lucky. I think it's looking pretty good for me. I'm hoping to sign something soon.
Nice.
Fingers crossed. I think if you're going to any major metropolitan area, there are opportunities.
Yeah, still.
That are, I would say, pretty reasonable. Still. Yeah. Not everybody gets to say that. Not every specialty gets to say that. And certainly if you were to go to a non-metropolitan area, the opportunities are endless and incredibly lucrative. I think.
Yes. I mean, that's certainly the case because, we can offer a lot of value to patients and practices. Yeah. And so as metropolitan areas are pretty saturated, nonetheless, there's still opportunities. And even you're competing with pretty big names in an academic setting, but there's still a lot of good private practices that are available.
There's so many. So many.
That's encouraging. And I think that should be important to mention because I think there's fears about, what am I going to do when I graduate? I hear reimbursements aren't doing that well. I hear, and I would hazard people thinking that way because it's even not about that in the first place, these reimbursements. It's just like about the interest of the field. Because I think pain is a human phenomenon that will be there forever. It's been there from the beginning of time and it'll be there till I guess we're plugged into ChatGPT, but exactly. I don't think there's going to be any end to this field, so I don't think there should be a lack of interest in it. But I think that it's going to wax and wane in terms of how lucrative it is and stuff like that. So.
That was kind of until we figure out a way to transcend the mortal coil.
How dare you say mortal coil?
People are going to have pain.
Yeah.
And we're always going to be looking for a way to treat it.
Right.
And we do have ways to treat it.
Yeah.
And I think that's why it's so important and why I enjoy the field is because there's definitely a need for it.
Right.
And there are people who are going to be very, very grateful for what you do as a provider. And that goes for a lot of fields. But pain is, I think, a particularly poignant one.
Absolutely.
And because of that, those opportunities, whether they be business or whether they be clinical, they exist.
Yeah. Or research even.
And you can create your own, which, as long as you have the drive and the motivation, there's almost anything you can try to do.
Yeah.
And this probably exists out there in a good sort of way.
Right.
Yeah.
What are 3 things you know now that you wish you would have known before you got into medicine?
Oh, man. These are 3 things that I wish I knew
Or
now.
one,
That's okay. I would say I wish I could have known how again, how much of an art this is. You shadow so many clinicians that are just, I mean, they're great with the needle.
Yeah.
And then you also go into the clinical setting and you're like, the pathway before the needle is very complex and requires a sort of touch and an art and a way to speak to people that I think is really challenging sometimes. It's hard to be nice when someone is really in a lot of pain and they can project that in a lot of different ways to a provider.
Right.
I think that's the first thing.
Mm-hmm.
I would say that number two, I would tell someone not to be overwhelmed by how much is out there.
Yeah.
Oh my God. They're like, every day I'm like learning about, like, someone will be like, there's this X company that's doing this. I'm like, that's
I know.
the first time I've ever heard of that.
I know. And it's like, even things that like are relatively common in the field that are not common in academic settings, like SI joint fusions or, spacers. And it's like still, I think we're still kind of figuring stuff out.
There's like place. Endoscopic spine surgery. There's
not being overwhelmed is a good point.
Like you will not. I mean, patients will be like, have you heard of this?
Like,
can you tell me your opinion? Like, I do not know.
Never heard of that.
Never heard of that.
You're right.
I can do some work. Let me figure this out.
Look into it for you.
That would be my second piece of advice. Don't get overwhelmed.
Yeah.
There's just so much to learn in a year.
Yeah.
And the third one is just like learn something every day.
Mm-hmm.
I when I first started fellowship, I actually I think I've told all the fellows this. I still do this. I'm not sure if everybody does still. One of the pieces of advice I got from a previous fellow was to just like start a Word document every day. At the end of the day, just put one little thing in there, or if you do a procedure or a new procedure, just write down like kind of how you did it.
The steps.
Yeah. Like just put the broad steps or like little pearls.
Yeah.
Because you're not going to run into the same procedures every day. And there have definitely been times when I look back on that Word document and I'm like, I had to do a DRG, like
right, yes.
and like I left notes for myself.
Yeah,
I told myself like, oh, like position it like this, or like, oh, like one of my attendings likes it like this, and it works really well. Like, leave those notes for yourself because it's a year and you're going to forget things, and you might do one procedure or two procedures in a month, never do them again.
Yep,
and then a patient in your whatever attending hood you choose will be like, oh, I have this option. You're like, oh, I remember we did that.
Right.
I have no idea how to do it anymore.
Right. Yeah. No,
So
that's really good advice. That's such good advice, honestly.
Leave those notes for yourself. I'm not really much of a note taker, to be honest with you. A lot of it's up here, but like I leave myself little like pearls in that Word document I started. Document's like 50 pages now. But
oh my gosh, dude.
There's just so much to learn.
You use Notes, the Notes app?
I just use a Word app.
Oh, okay.
Our hospital system has OneDrive.
Oh, okay.
So like you can pull OneDrive on any computer, including your personal computer.
Yeah.
So like at the end of the day, on whatever computer I'm on, I'm just like tap, like that's one smart. Bullet point.
Yeah, that's really smart. I think that should span all things within the medical field because, just at the end of the day, just some salient things that you can recall because you will forget them.
Everything.
So just that one piece, then you look back and it just jogs your memory like that. It's
like what the shortest pen is longer than the longest memory or something like that. Like that. You're gonna forget all of it.
Oh my gosh.
I like writing it down just because you have a record of all these like tiny little optimizations that your attendings have like developed over the years.
Oh my gosh, the shortest pen is longer than the longest delayed. These aphorisms that Dr. Vu's dropping. World of Pain MD, you heard it first. So then our last question, what do you think the biggest challenges are facing our field currently?
Legitimization. I think there are, again, a lot of different things to do. I think the evidence for them sometimes is difficult to find and difficult to substantiate. There are things we do really, really well and things that we have found work really well. This is definitely a field where innovation and technology and private companies kind of mesh all together. We are a procedural field, and as such, there are things we implant, there are things we place, and that leaves it very open to like working with private industry for better or for worse. So a lot of the interventions we sometimes offer, anecdotally, they do work. And I've seen patients that it does work. But if a patient would ask me, like, what's the percentage? The numbers are so gray and the research is so gray and a lot of it's industry funded. I think that you should be able to offer a wide variety of things. Even if things maybe are a little bit less, I think you want to offer them a chance and offer them options. And as long as you're clear and you have the experience to say, okay, I don't know if this will work really well with you, it's something you can try. That's an educated decision you can make between yourself and the patient. It's kind of this joint decision.
Yeah.
But it still needs more legitimacy in my eyes. I'm a pretty big skeptic about a lot of different things. And I feel like I would want to see more. I don't like the idea of experimenting on people.
Yeah.
And I really like to see more data on a lot of the different things that we do. It's great because, again, pain medicine is still an art.
Yeah.
But it should still have some sort of foundation to that art or some sort of basic tenet to that art.
Absolutely.
That I think we still really need to hone in on.
Yeah, I think you said it really well there. I will add in addition to that, and I think that might be a part of what I'm going to say, is that it seems our field is dwindling in applicants. And it's not seems, it is.
Yeah.
And I mean, we need anesthesiologists to be part of it. We need PM&R, neurology, EM. I know of a gen surge, specialist within the field, and I don't know how we can continue to facilitate this multidisciplinary effort. And currently, that seems to be on the decline. There was this paper recently released by Dr. Scott Pritzloff in UC Davis.
UC Davis, yeah.
Kind of about this very thing. And even now it looks like we're still having a declining amount of applicants. I think in 2019, there were 520. And in 2024, now there's 410. This last application cycle, this is in his paper, 35 programs went without an entire class of full of fellows.
Yeah.
So, I mean, it just goes to show you what's going on here, what's behind the scenes. And is it because we are not legitimized enough to have that data? So I don't know. I just suppose I'll pose that as the question. But I think, ongoing research and conversations, I think will help get us there.
I think a lot of people blame the hot anesthesia market. Which I think is actually a pretty big part.
Yes.
I do think it's still a challenging population.
Mm-hmm.
It's a challenging population. It's still a very technical field. And it's still, I feel like this field is still, it's been here for a while, but still kind of in its infancy.
Yeah.
We really don't have a great understanding still of why pain is there, or why it's so, not maybe so why, but how it's so subjective. It makes it so hard to treat. And I think sometimes I agree that pain could be its own training.
Yeah.
It's just such a mishmash of psychiatry and PM&R and anesthesia and gen surge,
palliative care,
cancer, even that it's hard to really get a full embrace of that within a year.
Yeah, absolutely.
Yeah.
Dr. Vu, Kevin, thank you for joining me tonight. I really appreciate your time, man.
Yeah. Thanks for having me. Don't let this dissuade you from doing pain.